According to U.S. News and World Report, there were 46 cyber attacks on hospitals in 2023, and that's up from 25 in 2022. I'm Christy Wojwoda, and I'm going to give you a brief snapshot of what we went through in 2020. This is kind of therapeutic for me, so thank you for listening. Just a little bit about my lab. We are an academic tertiary center, 620 beds. We're teaching hospital, and we are in a hospital network of 7 laboratories, of which we're the main reference laboratory. Additionally, we're in the Northeast Clinical Lab Alliance, again, where we serve as a primary reference laboratory. And we had transitioned from Sunquest to Epic Beaker in 2019. So this is a quick timeline, the beginning of a timeline of our experience. Day 0 was October 28th of 2020. We didn't know what was going on. Everything stopped. We kind of sheltered in place, went into routine downtime procedures until day 2. And on day 2, we learned that this was in fact a cyber attack, and that our IT folks noticed some funny network activity, and they're the ones that shut the network down. So the perpetrators couldn't get in any further. At that point, we were told that they were going to have to rebuild all of our systems, and that would take 2 to 3 weeks. And so we would have to be ready to deal with this for 2 to 3 weeks. So from day 2 to day 7, we were making sometimes hourly, sometimes minute by minute, iterative changes in order to function in a totally paper world. By day 7, the lab, we're procedure people. We got it. We kind of fell into a groove. It wasn't normal, but we knew what to do. By day 14, the lab again was trucking along, but the hospital was not. Nobody was used to looking in paper charts for results, and we were being inundated by phone calls for faxing the same results to multiple different providers. Up till day 25, we went back live. And if you think it's as easy as flipping a switch and going back to normal, it definitely is not. Not every system came back online at the same time. We had some oopsies where some COVID results were not being transmitted to our public health lab because our public health lab didn't turn back on our interfaces at the same time. And so we had a false spike in COVID cases in December of 2020. Day 30 to 60, we did a risk assessment to see, did we miss anything? Was there any real patient harm that occurred? Good news, we don't think there was any true patient harm. And we went through the task of figuring out what we were going to back enter into patient charts versus things that were just going to get scanned into scanned media in Epic, and we weren't going to bother resulting those out individually. That meant then that we couldn't charge for those tests, and so we definitely took a budgetary hit. It took us about 6 months until we really felt like we were past this cyber attack. So some quick tips that I can give to you guys. Something I wish we would have done sooner and more robustly is to stop the inflow. I keep saying it would have been better if all of our instruments went down. You know what to do if your instruments go down, right? You send everything out. Our instruments were still functioning. Our humans were still functioning. And so we were able to produce results. We just couldn't get them to anybody. So as much as you can, we closed down phlebotomy sites. A lot of our elective surgeries were canceled, but try to get as much work out of your laboratory as possible because everything just takes much longer when you're doing it all manually. Communication is extremely difficult because you don't have email. So you're going to have to do multiple huddles with all different levels of your staff and across the system. Your staff are going to be too busy and can't be interrupted, and so you're going to have to set up a call line for people to call to request results, and so you're going to need a system for that. Something that we learned was we didn't really know all of the people that were submitting samples to us, and so when we had a result for Dr. Smith, we didn't know where Dr. Smith practiced. We didn't know their phone number, their fax number. So we had this result with nobody to give it to. So keep an updated Rolodex, ideally on paper, of all of your providers and how to get in contact with them. If you're going to think about entering those results back in for billing purposes, think about all of the pieces of information you'll need for that. And then something that I kind of thought was brilliant at the time, I'm glad my CLIA director thought about it, was we set up a bouncer system. So there's 2 reasons for the bouncer. 1, keep the riffraff out. So old school docs are going to send their medical students and residents down to the lab to get the results, right? Or ask questions about the results. We can't have any extra people in the lab. You need your staff to focus. The other important piece about the bouncer system is, at least for inpatient samples, you can have them review the sample and the requisition to make sure that you have all of the pieces of information that you need to process that sample. For example, OR4 as an ordering location means nothing once we have that culture result back. The patient's way out of OR4, and we don't know. We don't have a system now to look up where they're at. You're going to need a place to fax results and file results, so get that set up. And there will be people who don't have things to do. So we had to furlough some of our outpatient clinic staff. Our radiology staff really couldn't do much because all of their work is electronic. And so we were able to utilize or repurpose those people in filing and faxing results. If your document control system for all of your SOPs is online, make sure that you have access to that, or make sure you have a paper copy available. A lot of our printers were networked, and so getting IT in to hardwire your printers to your computers at least allows you to print things out. We used encrypted USB drives to get COVID results to and from our public health labs, so you're going to want to grab a supply of those. And, depending on all of the plates that you set up, you're going to want a label printer because people's handwriting is pretty sloppy. And especially if they're going fast, it's impossible to tell what's on those plates. This is very, very stressful, I think, as you can probably imagine. And so you're going to want to take care of yourself, take care of your staff, make sure the leadership especially takes care of themselves, because everybody thinks it has to be all hands on deck all the time. And 25 days is too long for anybody to sustain that. You're going to need more bodies to just do the routine workload because it's going to take longer to handwrite out all of your results, your work cards, et cetera. So you're going to have to overstaff, develop shifts, and make sure that especially leadership takes 1 day off a week because otherwise people will burn out. You're going to have to, again, keep trying to communicate up and down across the system. Thankfully, maybe not thankfully, this was during COVID, and so there was a structure in place already at the hospital that the laboratory was plugged into, so we were part of that communication structure. It was really important for us to get out of the lab and go onto the floors to see what was working and what wasn't working for our providers, and I'll show you an example of what we learned from that. And then something, again, that kind of saved us was figuring out a mail merge for batch testing. So, an individual chemistry result could get printed out from the instrument, and that was your patient result. But if you have 250 COVID results coming off of your Panther analyzer, that isn't an individual patient result. And so getting that exported into Excel that could be printed out then in a Word document for an individual patient really helped us from having to handwrite those results. So this is an example of one of the communication tools we used. We got many, many calls on, is this blood culture still negative? So we put out a document saying, hey, don't call us, we'll call you if it's positive. We also put QR codes on there that led our providers to our test catalog, as well as new expected timelines. We also had one for reference ranges, because reference ranges are no longer on your reports, and how to do calculations like INR. So just to quickly wrap up, it's really hard to know what you don't know, but go home, take a look at your downtime procedures, and think about what you would need to be able to work through a process of 25 days like this. Look at your paper requisitions. We had no idea. I swear people found paper requisitions that still had bleeding time on them. So make sure you go around to your different sites, that they have appropriate requisitions for testing that you're still doing, and kind of do that in a periodic fashion. And then think about how you're going to file things and have a plan. We first started out filing things by day, thinking that that would be a good way to back enter things. But providers don't know what day they ordered something. They just know the patient name. And so come up with a convention, last name first name last, whatever it is, and make sure that everybody uses the same thing. It makes finding results much easier. My lab has kind of done a roadshow of this, so here are some references, both publications and webinars that we've done. And thank you for listening to my terrible time.